Hi, Caroline. Can you hear us? Yeah, so you are over to you.
Thanks, Aisha. Good afternoon, everyone. My name is Dr. Caroline Wood, and I'm going to be taking you through in more detail how we used theoretical frameworks from the field of behavioural science to underpin the design of the GASDA app. So here's Patty's slide from the previous talk, taking you through our methodology and our approach for the project. So firstly, in addition to referring to the existing academic literature as to some of the potential barriers to guideline compliant prescribing, we kicked off the project by carrying out an online survey and 4 focus groups to help us further understand the context of the challenge and specifically explore the barriers to compliant prescribing direct from health professionals themselves. Now, this rich data informed the technical development of the GASDA app, including the integration of evidence-based guidelines. It guided the overall design and interface of the app, as well as the character mentor that surgeons identified they'd be most comfortable taking advice from. Now, the final stage of the project involved a pilot testing phase of the app, where we invited surgeons across 3 hospital sites to use the app for real-time data collection when making prescriptions for surgical antibiotics. And we triangulated the data on barriers we identified through the survey and through the focus groups with reasons professionals gave for when they went against guidelines in the app and made a non-compliant decision. So it's these 2 points here that I'm going to talk you through now. So what do we already know about the barriers that might be occurring in Nigeria specifically? Well, looking to the literature, we could already see a number of reported barriers standing in the way of compliant prescribing. And Patty alluded to a couple of these earlier, including the practical and resource restraints, meaning that prescriptions can change as patients are handed from one part of the medical team to the next, and also meaning that prescriptions can often, for these reasons, be incomplete and maybe inconsistent as well. We could also see evidence of strong cultural norms existing amongst surgeons. You can see this study at the bottom by Kadia, finding that amongst surgeons with junior surgeons heavily influenced by more senior staff in the department. So with the online survey, the link was distributed via email and via the project WhatsApp groups we set up to communicate with the participants. And a total of 66 junior and senior residents provided us with their thoughts. We used a behavioural framework called the Theoretical Domains Framework to design the 30-item survey. And in total, we tapped 13 different behavioural domains to try and understand the key barriers that stand in the way of surgeons complying with prescribing guidelines. So just a bit more about the Theoretical Domains Framework, or TDF for short. It's a framework designed from a synthesis of multiple behaviour change theories, enabling it to provide a detailed analysis of what might be enabling or preventing a behaviour from happening. It's been used to analyse a wide range of healthcare-related behaviours, including prescribing. So participants were asked to rate their agreement or disagreement with items tapping, for example, the practical domain of skills, with questions such as, I have been trained how to administer the antibiotics according to the guidelines, and other domains such as professional role and identity. So for example, most people whose opinion I value approve of following the guidelines. Onto the focus groups. In total, we carried out 4 focus groups to delve deeper into the insights we found following the survey. And each group lasted for approximately 90 minutes and was facilitated by our partners in Nigeria at 2 of the hospital sites. And we structured the focus group questions using another framework, the COMBI, Model of Behaviour Change, and used the TDF, Theoretical Domains Framework, to guide probing questions where we had found that there were particular areas of interest, such as specific barriers or complexities of the practice that we just wanted to know a little bit more about. And in total, we gained thoughts from 28 of the junior and senior residents. Just a little bit more about the COM-B model. It provided us a very, very simple framework for understanding facilitators and barriers that might be in existence. So based on the premise that someone must have the capability, the opportunity and the motivation to enact a given behaviour, we asked our groups to discuss questions such as how easy guidelines were to access and to implement in practice, but also their thoughts on what the immediate and eventual impact of not following the guidelines would be. And you can see our lovely focus group participants here at the top. And just to give you a little flavour of the findings, what we found from the two different groups of data collection was really interesting. Now, all of the group were familiar with the guidelines and most were confident that they could, at least from a knowledge point of view, use them in practice to guide their prescribing decisions. Good access to guidelines was a different matter. Some said there were only a couple of hard copies of the guidelines available in the hospital somewhere, which made them very difficult to refer to easily. Which meant that most sought information online, which in reality could take just as long to find exactly what they wanted to. So beliefs about the consequences of what would happen with and without compliant prescribing was one of the key themes arising from both with participants explaining that the environment was their rationale for prolonging their antibiotic prescription beyond the recommended 24 hours as standard. As recommended by the guidelines. Some said that their prescribing decisions were limited by the surgical environment in Nigeria as well. We also saw evidence of what we were seeing come through from the literature about the cultural norms and junior staff following more senior staff's lead. So instead of referring to the latest guidelines, you've got a culture of senior staff passing on tips as to what had generally worked for them in terms of antibiotics and dosage. And duration as well. And there was also a suggestion that there was a lack of overarching policy and therefore any repercussions that if they chose not to comply with the guidelines, there wouldn't be any consequence as such from more senior staff or from policy governance. And this influenced their behaviour of whether to comply or not with the guidelines. On a much broader level, all of the group believed that guidelines were key to slowing the spread of AMR, but expressed a reluctance to apply them to the Nigerian setting unless there was good evidence, supported by research in the Nigerian context, that this would lead to good outcomes. Beliefs about patient behaviour also drove some of the opinion, prescribing antibiotics as a preventative through worry that patients wouldn't care sufficiently for their wounds post-surgery at home, have access to a local clinic that would do this for them, or concern that a patient's home environment was an infection risk. And all of these were popular and regular discussion points throughout the focus groups. Nigeria has a privatised insurance model where healthcare is considered a product or a service. And so surgeons said that there was a certain amount of pressure to prescribe from patients. And also, if they weren't prescribing at the hospital for patients, to collect at the hospital pharmacy. There was the idea that patients, or the worry that patients would get antibiotics elsewhere from perhaps unregulated sources and therefore risk their health. So to wrap up from these findings, our work with the teams in Nigeria shed a lot of light on barriers and facilitators to compliant prescribing and gave us a much better idea of what's going on in that context. And taking a behavioural approach enabled us to identify the key points in the prescribing journey where the GADSA app could make guidance easier to implement at the point of care. So we moved into the development phases with 4 takeaways in our minds. Firstly, enabling surgeons to add reasons for not complying with the guidelines and carry on that form of data collection and build that into the app would enable us to see how guidance needed to be shaped to increase compliance in the Nigerian context. The unique decision feedback within the GADSA app would aid surgeons' learning related to compliant prescribing. 3, that surgeons as well as other professionals such as pharmacists could value having an easy to access decision support system that they could quite literally reach into their pocket to refer to. And finally, that our work would open up much wider conversations in Nigeria relating to infection control policy and the potential risks presented by that very unique clinical environment. So just a thank to our funders and to our wonderful colleagues in Nigeria across the 3 hospital sites, all the surgeons, all the pharmacists and the residents who contributed their time and all of their very interesting discussion points to this piece of work. It really wouldn't have been doable without any of these people. So thank you. A final note, if there's any further information about the application of a behaviour change approach to the GASDA project, it can be found in this paper on screen now. And thank you for listening, and happy to answer any questions that you might have.
Thank you. Thank you for the presentations. Any questions? I didn't realize the antibiotics is such a kind of complex behavior issues, because you go to the doctor and you just have some prescription, and in different contexts it's quite different situation, different practices. Yeah.
Absolutely, yes. There's a lot of different actors and a lot of key behaviours that need to happen as part of that pathway, especially when there's guidelines involved. And as you saw from the data, there's a lot of cultural and social norms happening in that space as well, like the expectations of patients that they should receive antibiotics from the service. Naturally, no, not in all certain circumstances. So yeah, really interesting space.
Yep.
Thanks, Caroline. This was so interesting. I am wondering, so it looked like your hospital sites were, at least some of them were teaching hospitals. And I might be wrong, but maybe part of your subjects were residents and some maybe doctors. Was there a difference qualitatively in the needs amongst, young residents and doctors? It seems to me that they would represent different points along the education sort of capacity pipeline there.
Yes, you are absolutely right. I haven't mentioned it here, but it's mentioned in more detail within the paper. So I'd recommend giving that a read in a coffee break. But definitely, so we saw that typically the junior, not all, but the junior residents were more interested and open to the aspect of training and to receiving feedback on their prescriptions. We saw that obviously the cultural norms piece I've spoken a little bit to, but they're tend to be more influenced by the senior staff, so less likely to go against and make non-compliant decisions within the GASDA app. Trying to think of the other differences we saw. The type of antibiotics, there's also a difference there. So the more senior consultant residents were likely to prescribe more broad spectrum. So again, it relates to the guidelines, the confidence that this has worked before as a key attitude. So we're going to go with that versus the more junior opinions of the guidance says this, so I'm going to stick with this specific antibiotic. So yes, a lot of differences, and it was really interesting to see those come through in the data.
Thank you. So interesting. I'll definitely check out the paper.
Cool.
Any other questions? Is there any feedback loop between the doctors and patients in terms of the use of antibiotics?
Not within the GASDA app. Patty might be able to speak more to the plans that exist post this project, but the feedback loop is at the moment within the GASDA app is very much between providing feedback to the professionals entering the prescription decisions into the app, not to the patients.
Maybe there's a scope in the future developments.
Absolutely.
Yeah, so the purpose of this app is to inform the decision of the professional. So in this case, surgeons, and we may expand it to decisions which involve the team in other settings than just surgery. The purpose of this app is not to involve patients because it is a decision which is professional made and needs to follow the guidelines. So it would be inappropriate to use such an app for patients. However, there is massive scope and need for educating citizens as well. So
Yeah, the
definitely
citizen
gamified
science
app
approach,
would be
for
something which
example.
could contribute to this problem as well.
Thank you. Any other questions? It's very interesting, the behavior change as a model, as a underpin framework for these new developments. Thank you. So shall we move to the next speaker? So welcome to Susanna for our next speaker, talking about gamified antibiotic stewardship decision support app. Welcome.
Thank you. Do you hear me? Okay. Yes, so my name is Susanne Lüttke. I'm a public health specialist working at the Public Health Agency in Germany, where I'm leading the infectious disease department or infection control department. And I was involved in the GATSTA app when I did my master's in infection control at LSHTM, when then I joined Patty in doing my master thesis on the GATSTA app. So I'm going to talk about the results that we had when we evaluated the GATSTA. Naisha is leaving.
Yeah, that's fine. I will use your body language. Okay.
Okay, so we heard already that antimicrobial resistance is a very big problem in the world. According to the CDC, there are about 2 million people get infected each year and 23,000 die at least secondary to multi-drug resistant organisms that cannot be treated because there are no further antibiotics left. And according, that was also already in Patty's slide, that at WHO by 2050, we will have 10 million deaths per year due to infections with multi-drug resistant organisms. And it will cost the global economy over $100 trillion US. So why did we choose surgical site infections? Surgical site infections are associated with prolonged hospital stay, with readmissions, increased cost, morbidity, and mortality. Surgeons don't want that, obviously. Antibiotics are getting prescribed in the whole hospital, also especially in intensive care units, on the internal medicine ward, with especially in the oncology, hematology wards, where there are a lot of immunosuppressed patients, where you're especially concerned of infections which you need to treat. And often then you treat with like not only small spectrum antibiotics, you treat with large or broad spectrum antibiotics. No. However, with the surgeons, we needed a pilot project, so we needed to address a specific group of people where we could also measure it. And so we decided to go with the surgeons, also because surgeons often are very busy and they want to make sure everything is covered. So I just give the antibiotics. They do this with the surgical antibiotic prophylaxis. Like Patty already said, not everybody needs surgical antibiotic prophylaxis. It depends on the risk of the surgery and on the risk of the patient. But surgical antibiotic prophylaxis is a brief course of antibiotics, which is given immediately before surgery. And sometimes there's, if the surgery lasts very long, another dose. And that was for us, for the app, was a very good point where we could see if we can change behavior with the surgeons, because we could like define also how long is the antibiotic course, why is the antibiotic given, what kind of antibiotic is given. So a quick word to antibiotic stewardship programs in the world and in Africa. They're very important. In a lot of countries, they're mandatory by now, at least that there is a sort of an oversight of what antibiotics are given. They do help when there is a team that looks at antibiotic prescribing patterns of the hospital, gives surgeons feedback or medics feedback, then we see that the antibiotic consumption is going down, and that the development of resistant organisms is actually halted. So in low to middle income countries, not only in low to middle income countries, it's also in developed countries, but in low and middle income countries, there is a larger gap of not having antibiotic stewardship programs. And so in Africa, we only have about 15% of the countries have infection prevention and control programs. In Nigeria, is doing a little bit better with nearly 25% of tertiary care hospitals having an established antibiotic stewardship program. So coming to our study, to the results, we had 3 hospitals, as we said already. In total, we had the focus groups. In the end, we had 20 surgeons who participated in the study. Out of those, 80 were about 50% senior doctors and 50% junior doctors. We had 55% male doctors, and the rest was female doctors. The departments, you can see that ONG, so that's obstetrics and gynecology, they were the ones most heavily involved using the app, and general surgery. And then we had in general surgery, exactly. So yeah, we can continue. So we had in total 343 surgeries that were entered into the app, which on a user surgeon level ranged from 1 to 87 surgeries in a median of 9 surgeries per surgeons. The recommendations made to the surgeons by the application. So just to go one time more through the app for your understanding, prompted the surgeon after the initial choice to either proceed with their choice or to reconsider their choice. The first decision made by surgeon was classifying the surgical procedure as low or high risk. The second decision was to determine if a surgical antibiotic prophylaxis was needed or not. The third decision was if what type of antibiotic they were choosing, and the fourth decision was about the duration of the antibiotic. So that was basically our results. And the surgery risk, you can see we had, we gave either a point that was C, which is choice within the guidelines, or N, which was choice outside the guidelines. So surgery risk, you see we had 291 surgeries, which were correctly notified by the surgeons, or correctly chosen, and they didn't change their decision after getting feedback from the app. Then we had CN, meaning the first decision was right. They got the feedback from the app saying that was right, and they didn't change it. Then we had NC, first decision was not with the guidelines, was wrong. They got the response from the app that says that's wrong, and 37 surgeries, so 11%, they decided, okay, I'll change it to the correct decision. We had NN, which means the first decision was wrong. They got the feedback and they decided, no, I'm still not doing what you want. I'm continuing with my decision. So we had a significant change with a p-value of 0.01. that showed us that once they got a feedback from the app, they actually changed it to the correct decision. The SAP choice was not significant. However, we can still see they gave the antibiotic yes or no, basically, that's the SAP choice. And we had correct to non-correct. The choice within the guidelines was, now I'm confused. Yeah, the choice within the guidelines to not within the guidelines changed, but we also had a change within not within the guidelines and then correct within the guidelines. So that was not significant. The SAP type is what kind of antibiotics we were choosing. So we had 23 surgeries. So 7% of the surgeons decided to change their decision to the right antibiotic. So that was significant. And then we had the duration of the antibiotic. And also here we see that in 16%, the surgeons first said, no, that's not correct, and then changed it to a correct duration. So that was also significant. This is an overview of the antibiotics that were given. I don't want to go really into this right now, but we can see, for example, that first generation cephalosporin is a very narrow spectrum antibiotic. And we see that the initial recommendation from the app was that the initial choice from the that the initial recommendation from the app was to only give it in one surgery. Sorry, the initial choice was from the surgeon. They only gave it in one surgery. Out of all the surgeries, only one surgeon decided, I'll give just a first generation cephalosporin. The app, however, told the surgeons in 86 surgeries, you should get a first generation cephalosporin. And in the end, only 3 surgeons decided to change their decision. So there's still a lot of room for improvement, but it was like a nice overview what antibiotics we had. That's the duration. That was one of the points where we also had a big change. In the top, you see no surgical antibiotic prophylaxis was supposed to be given. Initially, only 28 surgeons decided we don't give any antibiotic, and then they changed it to 59. So we had a big increase there for example, no antibiotic at all. So in summary, we showed quite a lot of changes. I don't have a lot of time anymore, so I need to wrap up. But we showed that we had a 16% significant change to shortening the antibiotic course after feedback to be in line with the guidelines. Still 25% of antibiotics were prescribed without clear indication, but also that means 75% were actually prescribed with clear indications, which is good. Surgical patients were prescribed antibiotics for SAP, which were too broad in their coverage, which is still a problem. The reasons for not following published guidelines for following local practices, as was said before, also in Caroline Wood's talk, or the patient's environment requires prolonged doses. And the decision point about what antibiotic to use showed a significant 7% change towards the decision within the guidelines after receiving feedback from the app. And I think then we can, it's the same thing, continue. Thank you very much. I think we are done. We don't have more time.
So what's your impression of this research after you say there's a lot of room for improvement after surgeon give the feedback? And
so there is a lot of room in improvement. We have when we have our panel discussion, I think I'm not only talking about this, but also in other countries, like especially in Germany, where I'm right now, room for improvement, meaning we have, as was said before, we have the problem, there are no guidelines, no national guidelines. There's not enough education of the surgeons or the medics. And there is no antibiotic resistance profiles in those countries. So if I don't have those informations, then automatically I'm not going to follow anything if I don't have it. So we can see just with like the small app, or not a small app, it's a big app. So with the small, I mean, we had 20 surgeons with this, they even with like small informations they got throughout the day, we didn't educate them over hours. We just gave them like a little input, like, hey, this is, you should like not give them those antibiotics. And we still had significant changes to shortening antibiotics. And I think with this, we had, if this was ramped up, if the education with like with an app that's easy, like small handheld app, it's easy to use, everybody has access. In Africa, nearly everybody has a phone and has access to this, and so we can make big changes with that.
Thank you. Any other questions? On the back.
Please shout. Or an observation. I mean, I think this is really, really great. And so the interesting things for me are you've identified those key influential people in senior medics that maybe need to be targeted to encourage uptake. And also, I'd be interested in what the plans are to sort of follow up with this and to see if behaviour change and uptake improves over time in surgeons seeing better outcomes for their patients because of the decision they're making. Just wanted to get that something.
Yeah, Patty just left the room conveniently. I'm not that much involved in the project at the moment. Konza is here, she is involved. She's like, their plan is to start the project at the Wilmington. Which one? Whittington Hospital. We also want to kind of see if we can make a distinction between this as a junior doctor, this as a senior doctor, because we have those problems that were also mentioned before, that we don't know if the junior doctors are influenced by the senior doctors, and if we give them the chance to like just decide this for themselves, then we have a better understanding.
Any more questions? I wondered, the antibiotics, this kind of the dose, how the people actually, as I said, a lot of different behaviors involved, and it's a cultural thing, or is the kind of norm people use prescribe antibiotics is based on the professional practice, or is more kind of habitual?
I think it might be a cultural thing. We know in Europe, for example, in Denmark, or in the northern countries, Scandinavian countries, also there is much less antibiotic use compared to the southern countries, Spain, Portugal. They have much more antibiotic use. But we can see it, for example, in Germany. We can see it in the north. They use more antibiotic than in the east part. I don't know why. Also in the winter, for example, when everybody has a viral disease, everybody says, I need antibiotics. And some doctors, or a lot of doctors say, yeah, okay, I'm maybe a little bit unsure, could be maybe something bacterial, and then they give it. So, yeah.
So maybe the app can also discover that kind of differences. Thank you. Yes.
I just wondered if there were any plans to roll this out with primary care rather than with surgeons.
I am personally thinking about it, but we haven't discussed that yet. But yeah, I spoke to actually a colleague in the US who is a surgeon in like a private practice, and when I listen to his stories about antibiotics he uses, I actually just discussed it with him. I'm like, listen, I have this app there. Maybe we can like start doing so. So now we haven't formally discussed anything, but yeah, it's definitely an idea.
That's good. Good suggestion. Thank you. So we have a next speaker is online and Respoten.
Oh, let me.
So you're talking about supporting antibiotic stewardship in healthcare facilities through the global point reference survey of antibiotics of consumption and resistance.
Yes, thank you very much for inviting me for your 5th anniversary event. I'm very pleased to be with you. My name is Respoten. I'm based at the Laboratory of Medical Microbiology at the University of Antwerp in Belgium. And as mentioned, I'm going to talk about to you about the supporting antimicrobial stewardship in healthcare facilities by the use of a global point prevalence survey on antimicrobial consumption and resistance.
Anna, could you please share your screen?
Oh, I do share my screen. You don't see my screen. Okay, should I let me try again. Okay, I'm sorry. Let me try again. I thought I was sharing.
Okay, now it's working. Thank you.
Yeah, okay. Is it better like this?
Yeah, all good. Yeah.
Yeah, okay, thank you. Letting me know. So let me go straight away to the next slide, what we are talking about. Based at University of Antwerp, we are offering a standardized surveillance program called the Global Point Prevalence Survey. And there are 3 important points there that we offer. It's a way to assess and monitor antimicrobial prescribing, infections, community-acquired infections, healthcare-associated infections, and also resistance worldwide. Of course, you all know we offer a standardized method. It's a point prevalence survey method that gives you a snapshot in time of what antimicrobial prescribing is in an institution, in a hospital. But collecting data alone is not enough. You need to do something with that data. You have to move forward and link antimicrobial stewardship actions to it. So we do also provide in this way real-time standardized feedback reports with a benchmarking with national data and regional mean prevalence results from those participants also participating to the global PPS. So whenever those participants based in the hospital have participated in the global PPS, in that surveillance, they will thereafter, hopefully when investigating the report, be able to see and discover points where they can work on. For example, in surgical wards or in intensive care units, they discover issues where they can work on and they can set out interventions. And we try to offer really a very easy, simple way to measure antimicrobial prescribing, healthcare-associated infections and resistance. So it will be easy for them to repeat global PPS and in this way measure the effectiveness of these interventions. So these are the aims of the global PPS. We aim to identify the burden. First of all, provide survey performance indicators, because we have a lot of variables included in that survey, quality indicators, to allow participants also to identify targets for quality improvement of antimicrobial prescribing. It will help also the hospitals to assess the burden of healthcare-associated infections and related antimicrobial prescribing. So whenever they have the data, it is aimed to change practice. This is the course all about. It will help to support hospitals to design hospitals interventions and to promote appropriate use of antimicrobials. And also it helps identifying potential risk factors of healthcare-associated infections, because we also have an additional healthcare-associated infection module where we are more specifically interested in the use of invasive devices. So, and then measure the impact whenever hospital is able to set up interventions in the hospital, they will be able to assess the effectiveness of those interventions through repeated PPS. And that is actually instrumental in planning and supporting local and national stewardship actions. So what are the methods? Very brief. So we provide a standardized methodology to survey not only inpatients admitted in hospitals, but we recently also launched an outpatient module, just recently during ECMID 2023. And everything is available on our website, the protocol and the data collection templates. Beside that, we offer also a simple, freely available web-based tool. It's an application for data entry, validation, and feedback reporting. So we really, we have a dedicated team, IT team, to make sure that the data participants enter online, because it's an online web-based application, that there are as less as possible human errors and that we get as much as possible valid data. So you can start working with those data. You collect data, but actually it's like a quality improvement study where you should be able to set stewardship interventions in your hospital or in the future in the outpatient setting. Participation is on a voluntary basis, so there is no remunerations foreseen for the hospitals or the institution, but all the documents are freely available and also the application is freely available on our website. And also an important point I wanted to touch on is that it fully complies with data confidentiality principles. Not only the way you collect data on patients, but also there is a data confidentiality towards the hospital names. We all know that it can be very sensitive for hospitals to collect antimicrobial use data and resistance data. So we really take care of that very much. And that's also important for the sustainability of the project. And yeah, so a next point also concerning the method, I wanted to share that it is possible to participate as an individual hospital. So any hospital or any institution is free to participate, but also within a network. For example, we have a very big network in the Philippines. They participate with the Ministry of Public Health, and they centralize all the data, and they have the database from all the hospitals, over 60 hospitals participating in their network. And that is very interesting for them towards analysis. They can obtain aggregated results. So that's, I think, also a very nice thing. So the institution, as I can say, builds up an own database. Whenever you repeat the PPS, you have all those data in that database that is then there for the institution or the hospital. So a brief history, how we have grown. I was thinking maybe you're interested, where do we come from? So in 2014, we started with the protocol development and piloted also the global PPS. It is funded by bioMérieux. So we got funding in 2013. And then in 2015, we launched the very first worldwide global PPS. This one is also published. It was conducted in 53 countries, around 335 hospitals. In 2016-17, we expanded our network. And then in 2018, on the demand of our participants, we opened 3 surveys a year, so they could repeat the global PPS, the survey, within a specific year. In 2019, we introduced the healthcare-associated infection module, specifically to get more insight in invasive device use and morbidity factors, for example. And then we had a big drop. The COVID pandemic came there, and we saw it a lot in the degree of participation, that there were completely other priorities in the hospitals. So we recovered now the participation degree. Meanwhile, in 2018, we reinforced our team. I started back in 2014, but as we have grown, it became impossible and we needed to reinforce our team. So we reinforced our team in 2018. And also we have now a communication team who is helping us with the development of the website, of all kind of communication materials. The IT capacity has been enforced, and we also translated our website in 7 languages on the demand also of our participants. And then in 2022, we started to develop the outpatient module using also the method of a point prevalence survey, which I do believe is quite novel. In the beginning, I thought, yeah, just start it, we will go, but it was a rather tough exercise. And with the network we have, we were able to get, I believe, a nice protocol. And also the tool has been developed, so we launched it also now worldwide, now during ECCMID. So any hospital is also welcome to participate to the novel outpatient module. So this is a whole trajectory that I show to you, but that is really thanks to the voluntary support of the worldwide network, honestly, because we couldn't do that on our own. We got so much expert advice from hospital-based health professionals for protocol development. Many times we get feedback and we really try to take into account of their remarks so we can continuously improve and be of help to the hospitals to have a good surveillance program. Software testing or general comments from any participants. For example, they want to see specific feedback in the feedback report, and we think about how we can integrate that. So we are also bridging research interest between participants and institutions. We find it very enriching, really, the collaborations we see between the participants and us. So because we have a rather large network, this is really very interesting to work with, to share and transfer the knowledge. So I do believe it's the strength of our network and of our sustainability of the network, that we are rather transparent in how we work. When you go to our website, you will find nearly all of our documents. So this is the degree of participation up to now in America, South America. I'm not going to list it up, but you can have a look. So up to now, we have over 90 countries who have participating at least once to our survey, with a lot of different institutions and patients in the database. I'm not going to present you the results because, yeah, I was thinking maybe I give you an insight in how our feedback report looks like. This is, for example, our 1-point feedback reports, some slides that I took out. So they are presented in tables, in graphs, and the own hospital results will be plotted against country results, the continent, the hospital type also, because, for example, hospitals find it very interesting to be able to compare themselves. Imagine they are belonging to a tertiary care hospital, that they will be able to compare themselves to other tertiary care hospitals, and also Europe. So a new feature we also launched during ECCMID 2023 is the interactive online reporting, and it's provided to every participant. So it's provided through the Global PPS application. It's not public available through our common website. Why we decided to do this? Because we had also a longitudinal feedback report, but because data becomes so big, and the feedback report is programmed using R. statistical software package, and it took such a long time before the participant got the feedback report in his email box. So we thought that this would be very nice now, and then it's also on demand that you can ask, I want to have the results for this year, this type of ward, for example, or for this kind of antimicrobial subgroup.
It's difficult. Yeah, and you want to wrap up?
Oh, sorry. So this is all the presentations. I'm almost there. So I wanted to show you also one slide on the antimicrobial quality indicators obtained from the global PPS. This is a not exhaustive list, actually, not only the prevalence of antimicrobial use, but also typically quality indicators such as are local guidelines available, and if they are available, is an antimicrobial prescribed according to the guideline, is a reason being written in the notes. So this is a list, and maybe I jump here. This is one of my last slides. That I really wanted to show the collaborations we have also with other organizations. Like recently we have a European funding where we work together with the Radboud University Medical Center in Nijmegen in the Netherlands, where we really have a link between global PPS, where we collect data, and then the next step, how are we going to help our network towards sustainable stewardship actions. Actually, it's really a data-driven implementation of behavioral antimicrobial stewardship approach. We work also with the Commonwealth, and we have a database. Yeah.
I think we are over
Thank
the
you.
time.
Okay, thank you.
Sorry.
Thank you. Okay, that's my last slide. Thank you. I'm happy to take any question.
Yeah.
Yes.
So I will just have a quick question as we are out of time. So, and it's great that this project is collecting data from, did you say like 350 hospitals globally? And then as you said, the interesting thing is not just collect the data for the sake of data collection, but also have some action. And this is where we have been discussing it for over, a few years, how the project like GASDA can actually help to deliver intervention to hospitals who want to do something about the data they have collected to reduce their unnecessary prescribing. So do you want to comment how the GASDA can be linked to global PPS?
Yes, when I saw the presentations just now, I was thinking we have to get in touch again to see how we can collaborate, because truly it could well be that hospitals, when they see the feedback report, that they discover issues in their surgical prophylactic prescribing, for example. But of course, it's a snapshot in time. And by the way, it doesn't give you the details on the dosing and every time or the real duration. So with that app would be very interesting to introduce that. I think we have to talk after this and brainstorm and think together how we can maybe jointly work and offer our institutions, our hospitals, that bit more that you have that we do not have. So that would be really very interesting. Yeah.
Yeah, thank you. We can have the panel discussion later and questions and discussions. So the next speaker will be Dr. Aku Consuela Omar from the UCL Division of Infection and Immunity.
Aku is online. Yeah, can you join us? Yeah, we can see your screen now.
Okay, great.
Yeah, just if you go to the display mode.
Okay.
Thank you.
All right. Hi, my name is Aku. So I'm based at the Malawi Liverpool Wellcome Trust in Blantyre, Malawi. And I'll be giving you a talk about basically surveillance of the pneumococcus in a community that was exposed to mass drug administration of an antibiotic. So the pneumococcus is a global pathogen. It causes over 300,000 deaths among young children due to invasive disease. So the pneumococcus is normally can be normally carried by healthy individuals, and carriage is a prerequisite for transmission, as well as local and invasive disease. So local disease involves examples are sinusitis and otitis media, infection of the ear. But you also get invasive disease that includes bacteremia, sepsis, and pneumonia. So the pneumococcus is classified using multiple approaches. So serotype is based on its outer capsule. So there are over 100 immunogenic capsules. So vaccines are based off these capsules. So the vaccine we use here in Malawi is PCV13. So this covers against 13 out of the over 100 serotypes that are present. Sequence typing is based on 7 housekeeping genes. So this helps to define clonal population. So whether there's a particular outbreak of a certain clone, sequence typing is the approach. But to look at the lineages at a global perspective, there's a global sequence clustering approach. So this takes into account the entire bacterial genome. So you're able to study similar lineages across the world. So the pneumococcus has become a serious antimicrobial resistance threat. So this has been established by the CDC as well as the WHO. And one of the antibiotics that has been implicated are macrolide antibiotics. These are carried on mobile genetic elements. So these are basically, they can basically jump from one bacterium to another. So a particular type of element is integrative conjugative element, or ICE elements. So these elements are present in the bacterial genome. They can circularize and they can transfer to a susceptible bacterium, and then it integrated the genome, and all the descendants of those of that bacterium will have this element. So you can imagine in a community where you have macrolide selective pressure, it can allow the bacterium like this purple one up here to expand, and you have this as one of the dominant lineages circulating in carriage. But you also increase the reservoir of these lineages that have these elements. So bringing into the picture macrolide mass drug administration, macrolide MDA is used for trachoma control. So children are given macrolide antibiotics at specific times of the year. But there was a particular study published in the New England Journal of Medicine that was basically a cluster randomized trial involving countries including Malawi, Niger, and Tanzania. And they gave mass azithromycin to children 4 times twice yearly between 2014 to about 2018. The results from this was that in Niger only, there was a 13.5 lower all-cause mortality in the treatment arm compared to the placebo arm. But then this does have implications on other bacterial species, looking at AMR. So immediately after this study, in the short term and in the medium term, they saw that there was an increase in resistance amongst carried Streptococcal pneumoniae. So our question was whether this MDA results in long-term macrolide resistance and fixation of the elements that carry these genes. So our study was conducted in Mangochi district. So for the purposes of this talk, I'll refer to this as the rural site. So we have an archive of isolates that were sampled in 2015 at baseline, 2017, this is towards the end of the trial. And then we did a prospective carriage study in the placebo and the treatment arms about 3.5, 4 years after this. So this is what we defined as the long term. So we sequenced the isolates, looked at the population structure. So this is the sequence type, serotype, and the lineage. Looked at AMR genes and also identified the elements. So looking at macrolide prevalence, on the y-axis is the percentage of resistant strains. At the bottom is are the cohorts. So there's the azithromycin and the placebo. So you can see that from on the azithromycin side, there is a marked increase in macrolide resistance across the years, even in 2021 when the intervention was stopped. So you can see that the resistance has not gone back to the baseline levels of 2015, but we also noticed a similar increase in the placebo groups as well. So we are speculating that there's possible movement or dissemination of lineages in the azithromycin arm going to the placebo over time. But also mangoji is an area where there is a bit of trachoma. So there would also likely be some degree of macrolide usage in the placebo groups as well. So we compared these rates to that of an urban site. So this is hundreds of kilometers away from our rural site. And you can see that these rates are much far less than those that are seen in the rural side. So we can see that the effect of the mass drug administration on resistance persists in the long term. So we looked at the lineages over time. So one of the lineages that we highlighted was lineage 5, and this is what increased over time. So this is the 2015, 2017, and 2021. And then we have the placebo followed by the azithromycin arm. So you can see this increase. And the color that's showing the different colors, the green is showing the macrolide resistance gene was present, and the reddish pink is showing that the gene was present and it was on an element. So you can see that lineage 5 is an important lineage. And when we expand on this, we can see the sequence types. So lineage 5 was strongly associated with this 172 sequence type, and it was linked to a serotype 15A. So this 15A is not covered by the vaccine that we use. But you can see that it expanded post MDA, and similarly a serotype 35B, a sequence type 10599. So we can see that these lineages expanded and they're associated with resistance and ICE elements. So lastly, I won't go into this in too much detail. This is the phylogenetic tree showing the relationship of all the isolates we analyzed. And you can see this lineage 5, specifically here is the, where you can see in the lighter red is the serotype 15A, the serotype that I had previously highlighted. So what we had wanted to find out here was whether the elements that we identified in the serotype 15A sequence type 172 were similar to other lineages in our data set. So when we looked at the similarities, we did see that this lineage that had expanded was sharing identical elements to a serotype 6A. So this is a serotype that is covered by the vaccine. So this is suggesting that there is direct or indirect transfer of these elements. So I think either way that you look at it, I think it is important whether a vaccine type shared it with a non-vaccine type that has now disseminated into the population, or whether it's vice versa. So we're still looking into this in terms of how significant and how much sharing there is in the data set. So to conclude, we can see that macrolide resistance prevalence has not reverted to pre-mass drug administration levels. And the lineages that have expanded, and there are specific lineages that have expanded post-MDA. This may be due to antibiotic selection, but it may also be due to selective pressure from the vaccine. But when we did compare this to the Blantyre site or the urban site, you can see a very distinct difference in the prevalence. So most likely the lineages are different. And we can also see that the sharing of these identical elements does suggest direct or indirect horizontal acquisition, which may have broader implications in the larger data set. So overall, mass drug administration has a long-lasting effect on pneumococcal AMR. And I think there is a lot of caution that needs to be taken, particularly with some of these public health interventions involving mass drug administration. So thank you. These are the individuals I'd like to acknowledge. Thank you.
Thank you, Aku.
Thank you.
Seems we're slightly over time, so can I just kind of invite one questions for this talk? Anybody want to ask anything? Yeah. You, Patty? No? Any comments? If not, we're moving to the next section. Thank you, Aku.
Thank you.
All right. Thank you.
So we're moving to the second part of this section, and hopefully, if you don't mind, I will try to keep it short and we don't compromise our coffee break. So this section is about UCL grand challenges and GC exhibition. The first speaker is James Paskin, talking about the evolution of grand challenges.
Fantastic. Thank you, Marina. So along with me, Marina is 2/3 of the Grand Challenges team. I will do my best. I've only got 5 minutes and no questions, but I'm going to be over in the South Cloisters standing next to all the wonderful GC exhibition that we've managed to get, that we managed to get the UCL exhibitions team to help us build, which is just a brilliant overview of some of the work that's been done recently under the Grand Challenges. So I probably won't cover everything, but the very ambitious title is Evolving the Grand Challenge, the history, GCTT and going forward, which there's more than I can cover in 5 minutes. I'll just have the next slide. Thank you. So the Grand Challenges came from a commitment from the university that there was something that a large research intensive university like UCL could do to look at the problems, the really big global problems. So there are things that I think everybody in IIDR will be familiar with, is trying to make the world a better place through research and working with people on the ground. So we started on the cross-disciplinary piece, really trying to harness the cross-disciplinary power of the university. We've increasingly, as we've been working, we've realized that cross-boundary piece of working with people in different sectors is just as important. So one of our aims is to increase mutual knowledge and engagement, but also to work in co-design and co-production, use co-design and co-production approaches so that we can get solutions that really work. And to do that, we need to work with the experts, who are all the people here in this room and all the people spread across the university. Have the next slide, please. So again, probably saying some of the same things again. One of the key insights is, I'm going to say this again, but solutions don't come from a single field. We've always had this reliance on cross-disciplinary rather than interdisciplinarity. And part of that is this idea of people with T-shaped skills. They've got very thick trunks. They understand their disciplines, but they're also very happy to branch out and work with people from across the university. And as I say, working beyond the university as well. So we are part of research, innovation and global engagement. So not only do we have our own team in the research piece, we also work with the innovation teams and the people in global engagement. So next slide. This is a rather confusing slide, which just shows the results of one of our recent funding schemes. Down here, we've got the UCL lead faculties, and they either work with partners within UCL, and you can see those in the kind of orange there, but we've also, as I say, we've been encouraging people more and more to work with people outside. So these blue links here are people within UCL linking to places outside. Next slide. Thank you. Oh, yeah, you will be able to see the Grand Challenges exhibition for a limited time only in the South Cloisters. So we had a great launch, a very well attended launch here. I like this picture because it really shows how many people were milling around and trying to get a look. You'll see behind there's the Neo Tree exhibition with Ian and Olivia chatting to each other in front of it. I forgot to put mantra on the slide, so I beg your forgiveness. I'm really sorry. But Neo Tree was one of our star stories. It was one of the things that we knew we had to, when the exhibitions team came to us and said, what do you want to talk about? Neo Tree was one of the ones we wanted to have up there, as was our link with IRDR, because Grand Challenges has been linked to IRDR from the very early days. So we were, so Ian Scott, who you see there, was closely involved in the beginnings of helping IRDR get set up. So so he's kind of a godfather of IRDR, I think we can say. Sorry, next slide. Oh yeah. So I promised I'd talk about history. GCTT I haven't really covered, but I can talk a little bit about the future. So we currently have 6 grand challenge areas. These are all being replaced. So the strategic plan has completely changed the way we're thinking about the grand challenges. We're extending our scope. So we've been very much in the research space. We're going to be moving more into the operations. So trying to bring the insights from grand challenges work into the way the university is run. And this one really scares me because I know nothing about it. Education, how we can use grand challenges insights to teach people in the university. And also we're going to have identified academic leads who will be paid by the grand challenges to lead these new areas. So have the next slide. Fantastic, thank you. So here we have the challenge areas we already have, and they're all being transitioned. So over the next 5 years, we will move completely from these into these new challenges. So next year we'll see climate crisis and mental health and well-being coming in, replacing services and human well-being. Transformative technology will be replaced by data-empowered societies. At least that's the plan so far. But all of these, I think, all of the new areas certainly have got can come into the work of IDR, and certainly and dPHE I think has definitely got a part to play in solving a lot of these. So I think I'm going to have to wrap up. And if you want to ask me some questions about the grand challenges, I will be milling around and drinking coffee. So there might be another slide with just our contact details. Thank you.
Thank you, James. So another case study for the grand challenges is the mantra. So Patty will talk about that.
So sorry, it's me again. So we're going to be showcasing one of the projects, which is the star project in the exhibition called Mantra. So just very briefly, I have the Mantra on my phone. So if you want to come to talk to me, you can even have a play with Mantra on the phone. So this is a game which is based in Nepal, so like a tiny country in the Himalayan region. And our purpose in this NERC-funded project was to develop an app for women who live in rural part of Nepal, who are living in a very remote part. They have to walk, some of them 2 hours, to meet us in those women sessions in the central village where we did this project. And we have developed a game which was aimed at people with low literacy or even illiterate who have never used their smartphone before in many cases. And we have to develop something which they would grasp the knowledge and gain very quickly to improve their confidence about maternal and neonatal health through the game, and empower their decision making to know when they should be using and when they shouldn't be using healthcare providers. So as I said, the Mantra has got 3 different parts: maternal health, neonatal health, and also geohazards, which are a very common reason for death in especially around the earthquake. And more people died as a result of neohazards than during the actual earthquake. So as some of the people have not actually used a smartphone before, we have to develop a little tutorial for touch and play. So they have this picture was a baby in the arm of the mother. They have to move the baby back to the arm to actually learn how to operate the smartphone. So really challenging, but really rewarding project to work with people who haven't used the smartphone before. The game had got just pictograms. We were with very gifted artists and the local people to understand what these images would mean to them, to their culture, to be able to depict the common conditions for maternal and neonatal health. And they were not getting points in points, they were getting points as a little leaves on this flower you can see on the side, because nothing could be done in numbers and letters to address the literacy issue. And this is a very busy slide to show that we have achieved a behavior knowledge change around the 3 different modules, especially around some of the objectives highlighted on the other side. And we also got 2 projects, 2 awards for this project. It was a finalist in Diversity Project of the Year, and my colleague Caroline Wood and I got a Best Partnership Award for Mantra. and some publications for those of you interested, but also you interested in the actual game, come and see me in the Grand Challenges show and you can see the game.
Thank you. So the next one is Dr. Emma Wilson, talk about the new trees.
Hello, good afternoon. I'm so delighted to hear that Neotree was a star story at the Grand Challenges exhibition. That's wonderful news. So yes, my name's Dr. Emma Wilson. I'm a senior research fellow at the Institute of Child Health, and I'm just going to give you a very quick overview of Neotree on behalf of the Neotree team. Next slide. So the problem we face is that every year 2.4 million babies die within the first month of their lives, and most of these deaths occur in low resource settings. And we also know that about 30% can be prevented through improving postnatal care and particularly adherence to evidence-based guidelines. So our solution is Neotree, which is an open source data capture and visualization tool alongside education, clinical decision support, and quality improvement. So kind of all singing, all dancing. Next slide, thanks. And we're currently implementing in 3 tertiary settings, so 2 hospitals in Zimbabwe and 1 in Malawi. And I'm delighted to say that we recently got some funding from the Foreign and Commonwealth Development Office to start piloting at sort of lower level facilities, so a community hospital and a primary care site in Malawi. So that's new work that we're embarking on. So just to give you a brief overview of the sort of key features of Neotree. So the first thing are electronic healthcare records and data visualization. So data is captured on admission and discharge, as well as laboratory results for every admitted baby to these hospital facilities. So that allows clinicians to track case-specific mortality rates, as well as sort of performance against key quality improvement metrics that they may have decided on in their particular facility. And in addition, we have clinical decision support, education and training, and these are based on evidence-based algorithms. And finally, Neotree is the back end of Neotree. There's ease of configurability. So this means that the content and the guidelines can be easily adapted to sort of local guidelines and also sort of the equipment and resource needs of those particular settings. So I mentioned the primary care facilities that we're going to adapt to. So obviously the equipment and the sort of skills level there is very different. So the back end, we can sort of adapt that. We can adapt the guidelines in the back end of Neotree quite easily. And then finally, data linkage. So Neotree allows data linkage to national aggregate databases. So in Malawi, we've shown proof of concept to linking to the DHIS version 2. And in Zimbabwe, we've nearly completed work for the push functionality to the National Electronic Healthcare Records, that's the Impilo system. So that's very exciting because hopefully quite soon Neotree will be able to export directly into the Zimbabwe EHR. And just to mention some ongoing work that's been funded by UCL Grand Challenges. So colleagues are using machine learning methods to refine a predictive model for the diagnosis of neonatal sepsis. And what they found is machine learning techniques have performed better than logistic regression models, and external validation and refinement is ongoing. And then also a project that's been led by my colleague, Dr. Nusrat Khan and Professor Tim Colburn, to see how we can better use Neotree data to monitor and sort of measure key quality of care metrics. And actually, we've just come back from Zimbabwe and Malawi, where we met with Ministry of Health officials and also local clinicians on the ground to try and decide what would be the key metrics, both at sort of local ward level, but also at the national level, that we could use the data to monitor. And I think the great thing about Neotree data is that it's in real time, and so that we can have real up-to-date sort of idea of how they're performing against these metrics. Slide. And of course, next step. So we have to, an intervention is never fully cooked, as it were. We're continuing to optimize the functionality, ongoing research and analysis, so refinement, optimization of the sepsis algorithm, and implementation evaluation research. So we're seeking funding to do a sort of large-scale evaluation to hopefully show the effectiveness in case fatality rates. And yes, and we also have an ongoing program of public engagement where we're working with mothers and caregivers to ensure that care pathways in the facilities that we're working with are family-centered. And yes, thank you to all our partners and funders. And I'll be around, I think, later if anyone has any questions. Thanks.
Thank you. I just want to remind us, this section is called good box and bad box. So the next few short talk will about the good box, I guess. The first one is, the next one was Catherine talking about cheese.
So, hi, I'm Catherine. The work that I'm going to show you today has been funded by Grand Challenges Transformative Technologies. And I've taken a very familiar path through my PhD. I recently finished. That's what it looked like. And what I did was I quantified dietary change for the last 30,000 years. And of course, one of our largest shifts in diet has been the inclusion of milk from other animals, exogenous milks in our diet. Not all populations, but some populations. And of course, this is something that we've adapted to biologically. So we have 5 genetic adaptations to this change in diet. But of course, we also adapted culturally in the form of making cheese. So I'm going to show you some of my work on cheese today. So we know that the oldest evidence we have for milk in human diets comes from the Fertile Crescent about 9,000 years ago. The earliest evidence we have in Europe is from Poland. We have 2 sites where we've got milk lipids embedded in those potsherds. The earliest cheese making is from Croatia, shown in the middle. We also have this lovely female mummy from China from 3,800 years ago. And she's buried with a kefir cheese necklace. We've done proteomics on the milk that's in the substance, and so it's been confirmed that it is it's a dairy product, kefir. So closer to home, we have Cheddar Gorge, which that was formed millions of years ago in Somerset. Cheddar Man actually didn't drink milk. Cheddar Man is pre-Neolithic. The Neolithic in Britain is about 6,000 years ago. Cheddar Man's 10,000 years old, but the genomics and a lot of the analyses were done in our lab here at UCL. And then Cheddar Gorge today is made for what we now are storing cheeses in the gorge. So you can buy cheddar cheese. Cheddar, it gives its name to our most famous cheese. So I wanted to look more at this cultural innovation. So what I did is I teamed up with a cheesemaker in Cumbria working with sheep's milk, and Neil's Yard provided free transport for all of my samples to London. And I was working with a colleague at London School of Hygiene and another colleague here at UCL. And we did all of our DNA extractions in our Darwin labs, and then 16S sequencing. So we've done next generation sequencing on the samples. And what we found in some ways was what we expected. We expected higher microbial diversity in the raw milk. And we've got samples, raw milk from indoor reared and outdoor reared sheep. And then we were able to go down to the species level. We developed our own pipelines to look at the microbial diversity in the milk and starter culture in the cheese. And I think this is where it gets really interesting. So here, these are my 3 samples of indoor reared milk from indoor reared sheep. And what you can see is that from handling the bedding and handling the animals, you can see the staph hominis, so staph from the hands of the farm hands, is transferring into the milk. And what you can see in the outdoor reared sheep is a much higher microbial diversity. And what I find really interesting about this is that if you ask any cheesemaker, they always add less starter culture to those outdoor reared milks. And this is starting to explain why. And the other really interesting thing that we found was the Lactococcus lactis, which is the main bacterial component in the starter culture, completely overwhelms and outcompetes any of those microbial diversities in the raw milk. Go to the next slide. So what I'd like to give you just a few takeaway messages from today is that that we've been able to confirm through cheese genomics that the microbial diversity is higher in the raw milks and higher in the outdoor milk than in the indoor reared milk. That the starter culture is almost acting like a pasteurization process, not by heat, but by microbial competition, and it outcompetes any strains that you wouldn't want to be consuming live in your cheese. But I think what this really does is it shows us that by using modern technologies, we can really start to understand and pick apart these embedded technologies within our traditional food processing. And tonight, if you'd like to try any of our cheeses, I've brought samples for you to try. And I'd just like to thank the team and Transformative Technologies for funding this work.
Thank you. I can tell you the cheese is really tasty, so stay along. And the last speaker of the section, Jelena, will talk about fermented food.
Hi, thank you for inviting me to take part in this. My name is Jelena Belgrave. I'm on the advisory board for Fermenters Guild and also a member of the Guild. And I'm here to represent the bugs. We are the shepherds of microbes in our guild, which means that there's over 60 educators, producers, nutritionists, scientists in our guild who are there to protect the traditional ways of using microbes to alter food and create novel foods as well. So what is food fermentation? So this is obviously a transformative action of microbes that transforms food from one form into another. And obviously this has been used way before we sort of invented pottery, but since the moment we started using pottery, we have over 10,000 years, we have evidence to show that humans have been fermenting foods. What we talk about when it comes to fermentation, we talk about wild fermentation, so using microbes that are naturally present, whether in soil or on products, or in particular territoire, without adding starters to foods. So obviously with Louis Pasteur, who defined the science behind fermentation, we started getting more interested in microbial fermentation and trying to understand the food technology behind it. So people around the world fermented throughout the ages. You can find it in Inuit people, you can find it in the Balkans, you can find it in Asia, you can find it in any culture around the world. Even here, when people say, well, we don't ferment in the UK, yes, we do. We have cider and we have cheese and dairy fermentation. So you can find examples of it absolutely everywhere. That little chili over there, so this is a traditional Chinese fermentation vessel, and this is a rice wine. And the chili over there on top of there is supposed to ward off evil spirits as well as be antimicrobial and prevent some of the wild yeast of getting into the vessel. Obviously, so many cultures have consumed fermented foods throughout decades and centuries, but only recently has the scientific community started investigating from fermented foods. And so one of the highlights, one of the studies that I would like to highlight is the Stanford School of Medicine one that looked at nutritional targeted sort of diet changes that can increase microbial diversity as well as reduce inflammation markers. So that's the study down link. If you want a link, I can also email it to you. we are very interested as traditional fermenters at what's happening in the precision fermentation community. Obviously, when I ferment at home, for example, or when I teach somebody, or I travel and carry my cultures with me, I use and rely on wild microbes. But precision fermentation has been with us for over 30 years, 40 years, 50 years. Obviously, you know, that's the rennet, vegetarian rennet that precision fermentation has made and is used 90%, 95% in cheese making nowadays, but also insulin and precision fermentation is responsible for that. So it's really interesting how precision fermentation is moving into the food sector and how it can impact a creation of novel products using microbes. There is a lot of space for traditional fermentation methods still to be said. There's a lot of funding going into science community as well as food production community, and a lot of startups looking at microbial food fermentation and how they can work together. It's what Catherine was saying just a moment ago, that what's happening in UCL, the same sort of genomic sequencing is happening in other universities across Europe and across the world. European Union has funded a massive research inviting science and technology experts to come together with traditional makers to look at fermented foods, what they mean for our health and what that means for sustainable food source for everybody. Thank you.
Thank you. So thank you for all the speakers, including the online speakers. And we are coming to the end of this section. I just want to say that we have sample to taste, but you have to stay to the end. And now we have the coffee break, and everybody can interact with each other and have a short conversation. See you later. Thank you. Yes.